Right now, somewhere behind your eyes, optic nerve fibers may be dying that will not grow back. By the time you notice the symptom most patients notice first, nearly 40% of those fibers are already gone. Glaucoma does not warn you the way a heart attack does. It does not hurt. It does not blur. It quietly steals nerve fibers from the back of your eye, one by one, until one day you notice you can't see what used to be there. By that point, the damage is permanent. No surgery brings the fibers back. No laser, no drop. The vision you've lost stays lost. There are 3 warning signs that show up before the loss becomes obvious. Most seniors miss them. By the end of this video, you won't. I'm Dr. Richard James, and after more than 3 decades in clinical medicine, I have seen far too many patients walk into the eye doctor's office with vision loss that could have been prevented if someone had checked one simple number 5 years earlier. Glaucoma is the second leading cause of blindness worldwide. Roughly 13% of adults over 60 have elevated intraocular pressure, the single biggest modifiable risk factor for glaucoma. Most of those people do not know they have it. The disease has a 5 to 10 year silent runway, during which damage accumulates without symptoms. If you are over 60 and have not had your intraocular pressure checked in the last 12 months, you may already be in the silent runway. Glaucoma damage is permanent. Once nerve fibers die, no treatment brings them back. The only intervention that works is catching it before that point. Half of the glaucoma patients in this country do not know they have it. Not 1 in 4. Half. The CDC estimates this is one of the most underdiagnosed serious eye diseases in the United States. The Ocular Hypertension Treatment Study, one of the landmark trials in this field, showed that detection plus pressure-lowering treatment cut the risk of progression in half over 5 years. The intervention works. The intervention has worked for over 2 decades. The bottleneck is detection. This is not a rare disease. It is a disease most of the people who have it have never been told they have. The harder question isn't whether glaucoma is dangerous. It's how you know whether you are in the half who has it and doesn't know yet. The 3 warning signs we are about to walk through are exactly how you find out. Stay with me, because the difference between catching it and going to the eye doctor 5 years from now with vision you can't get back may come down to recognizing one of the next 3 patterns in your own daily life. Sign number 1, peripheral vision narrowing. This is the most common first warning sign of glaucoma, and it is also the most dismissed. The reason it gets dismissed is that the loss is gradual, and the brain compensates by filling in what's missing. Patients describe it as, "I bumped into the doorframe again," or "I keep missing the side mirror when I park," or "I didn't see the dog until she was right in front of me." It is rarely connected to the eyes. It is usually written off as clumsiness, distraction, or just getting older. Here is the mechanism. Open-angle glaucoma damages the retinal nerve fibers that carry peripheral information first. Central vision, the kind you use for reading, faces, screens, is preserved until late stages. By the time central vision is affected, peripheral loss is severe and irreversible. The reason peripheral vision goes first has to do with how the optic nerve is wired. The fibers carrying peripheral signals enter the optic nerve at the most pressure-sensitive part of the disc. Elevated intraocular pressure squeezes those fibers first. The fibers carrying central signals are protected for years longer, which is why central vision feels fine until the disease is advanced. The brain, of course, is doing its part too. It fills in the missing peripheral information from memory, expectation, and cross-referencing both eyes. That is why the loss can be invisible from the inside, even when an examiner can see it on a visual field test. You can do a rough home check tonight. Pull a piece of paper, cover one eye, stare at a fixed point on the wall in front of you. Wave a finger from the far edge of your peripheral vision toward the center. The point at which the finger first becomes visible should be roughly the same on both eyes. If one eye sees the finger noticeably later than the other, if there is a clear gap, that is a clinical sign worth checking. This is not a substitute for a real visual field test in an ophthalmologist's office. It is a way to make the question concrete enough that you actually pick up the phone and book the appointment. This is exactly where most patients fail themselves. They notice the bumping. They notice the missed mirror. They blame their hands or their attention. The actual problem is in the optic nerve. and the optic nerve is screaming for someone to measure its pressure. Now, the next sign is one most seniors notice but never connect to glaucoma, and it shows up specifically in the kind of light where most over 60 driving happens. Sign number 2. Halos around lights and difficulty driving at night. You start noticing rainbow halos around streetlights, around oncoming headlights, around the porch light when you take the dog out at night. You start avoiding driving after dark, not because you're tired, but because the lights confuse you in a way they didn't 5 years ago. Both of these together, the rainbow halos and the new difficulty with night driving, are pointing at the same underlying issue. Your intraocular pressure is spiking, often overnight or in low-light conditions, and the cornea is taking on extra fluid in response. That swelling distorts the way light enters the eye, which is what creates the halos. At the same time, the peripheral nerve fibers that are already starting to fail in early glaucoma are the same nerve fibers that handle low-light vision. So you get a double hit. The cornea is misbehaving. The retina has less to work with. Driving at night, where contrast is already low, becomes the canary in the coal mine. This is the part that quietly costs people their independence. Many seniors stop driving at night, not because of cataracts, not because of macular degeneration, but because of undiagnosed glaucoma that has been progressing for years. Independence shrinks quietly. The dinner with friends turns into, "Let's meet at noon next time." The grandchild's evening recital turns into, "I'll catch the next one." The pharmacy run after dark turns into a delegated errand. The world gets smaller, one decision at a time, and the underlying cause is a pressure number nobody has measured. This is also where I see the most preventable damage in clinic. By the time the patient connects the dots, books the appointment, and gets the visual field test done, the loss has often crossed a threshold that no treatment fully reverses. The drops can stop progression. The drops cannot give back what was already taken. If you have noticed either of these signs in the last 12 months, the appointment for a comprehensive eye exam is not optional. It is the single best use of an hour of your week. Now, the next sign is the one that genuinely scares me. If you have it and you do not call your eye doctor today, you risk losing vision in 24 to 48 hours. Sign number 3. Sudden, severe eye pain with nausea and vision changes. This one is not a wait-and-see symptom. If you wake up with severe one-sided eye pain, with nausea or vomiting, and you see halos that are dramatically worse than usual, with a headache that does not feel like your usual headache, that is the emergency room, tonight. The medical name for what you may be experiencing is acute angle closure glaucoma. The angle between the iris and the cornea closes off, blocking drainage of the fluid that maintains intraocular pressure. Pressure rises rapidly. The optic nerve is starved of blood. Permanent damage begins within hours, not days. Acute angle closure glaucoma can destroy the vision in that eye in 24 to 48 hours without treatment. There is no version of this where you wait until Monday. There is no version where you take a pain reliever and see if it gets better. It is rare. It is dramatic. And every emergency department in the country has seen it presented as a migraine, then realized 2 hours later it was the eye. The people most at risk are over 60, more often female, often with a family history, and often far-sighted. The treatment, when caught in time, is straightforward and effective. Eye drops to lower pressure, sometimes oral medication, sometimes an intravenous medication called mannitol if pressure is severely elevated. Sometimes a laser procedure within hours called a peripheral iridotomy that opens a small hole in the iris and prevents the angle from closing again. Caught early, the vision is preserved. Caught late, it is not. The hours you spend deciding whether to go in are the hours that matter. Many patients come in believing they have a migraine and are told to wait it out. The check that distinguishes the two is straightforward in any emergency department with eye-trained staff. A pressure measurement, a slit lamp look at the cornea, an inspection of the angle. 5 minutes of clinical work that decides the rest of the eye's life. If there is one thing to take from this section, it is this. Severe one-sided eye pain in someone over 60, with nausea, with halos, with vision change, is an eye emergency until it is proven otherwise. Treat it that way. In a moment, I'm going to give you the exact 4-question conversation to have at your next eye exam. But first, I need to address the one question every patient asks. How do I get tested before any of this happens to me? The most common objection I hear is, I get my eyes checked every couple of years. I'm sure my eye doctor is already screening for glaucoma. Two issues with that assumption. First, the routine eye exam most adults get may or may not include a tonometry test, the actual pressure measurement, and a dilated optic nerve examination. Vision correction-only exams, the kind you get when you order new glasses, often do not include either. A glasses prescription does not require pressure measurement. So if your last eye visit was a glasses appointment, you have not been screened for glaucoma. You have been fitted for glasses. Second, even when intraocular pressure is measured, single time point readings can miss the patients whose pressure spikes overnight or intermittently. The current state-of-the-art in early detection is OCT, optical coherence tomography of the retinal nerve fiber layer. OCT can detect glaucomatous damage years before visual field loss. Most modern ophthalmology offices have it. Many optometry-only offices do not. There are two different things people call eye exams. One is the test for a glasses prescription. The other is the medical eye exam that includes pressure measurement, dilated optic nerve assessment, and ideally, OCT. The first one will not catch glaucoma. The second one, done every 1 to 2 years after age 60, is the standard. If your last eye visit was for new readers and the optometrist did not put a drop in to dilate your eyes, you have not been screened for glaucoma. The exam you actually need is the comprehensive medical eye exam. After 60, the recommendation from the American Academy of Ophthalmology is every 1 to 2 years. Once you have any risk factor, every year. Here is the synthesis. The point of this entire video. Glaucoma is the rare disease where catching it early changes everything, and catching it late changes nothing. The intraocular pressure measurement is one of the simplest, cheapest tests in medicine. There is no excuse in 2026 for half of the patients with this disease to not know they have it. The 3 warning signs we walked through are not the diagnosis. They are the smoke that tells you to look at the smoke detector. If you are over 60 and you have not been screened with a comprehensive eye exam in the last 24 months, you are functionally untested for the second leading cause of blindness in the world. That is fixable. The fix takes 1 phone call and 1 appointment. Most viewers watching this right now are probably in that uncertain category. That is normal. The question is not whether you are safe today. The question is whether you and your eye doctor are actively working off real measurements or off assumptions. Real measurements take a few extra minutes per visit. Real measurements give you a number you can track year over year. Real measurements turn glaucoma from an invisible threat into a managed condition with a clear treatment ladder. Drops first. Laser if drops are not enough. Surgery for the small fraction who need it. That ladder works. The ocular hypertension treatment study showed it works. Decades of clinical experience confirm it works. The single biggest barrier between you and that ladder is whether someone has measured your intraocular pressure in the last 12 months. By the end of the next 90 seconds, you will know exactly what to ask for. Here is exactly what I want you to do. This week, call an ophthalmologist's office, not just an optometrist for glasses. Ask for a comprehensive medical eye exam with intraocular pressure measurement and a dilated retinal exam. Use that exact phrase. Insurance generally covers this once every 1 to 2 years for patients over 60. Medicare patients are typically covered annually for glaucoma screening if they have any risk factor. At the visit, ask 4 questions. First, what was my intraocular pressure today in millimeters of mercury? Get the actual number in both eyes. Write it down. Second, did you image my optic nerve with OCT? If yes, get a copy of the report. If no, ask whether OCT is recommended for your age and risk profile. Third, given my age, family history, and current pressure, what is my glaucoma risk category? Fourth, when should I come back and which symptoms warrant calling immediately? If you have any of the 3 warning signs we covered today, mention them by name. Do not soften them. Do not say, I think maybe. Say, I have noticed peripheral vision changes, or I have noticed halos at night. That precise language pulls the workup into the right shape. Tonight, look around your home. Identify the people in your family who are over 60 and have not had a comprehensive eye exam in the last 2 years. Forward them this video. The CDC's "half don't know they have it" statistic only changes when people with this information move it. If someone in your family is over 60, send them this video tonight. You may never know it, but you could be the reason they keep their vision. I'm Dr. Richard James. Subscribe because next week I'm covering the medication that quietly raises eye pressure in seniors who take it for joint pain. That's the video that pairs with this one. Take care of your eyes tonight. They have shown you everything you've ever loved.